next speaker. He needs no introduction. We all know Dr. Boonprasit. He's going to talk about the optimal treatment for uncomplicated acute type B aortic dissection.
Well, thank you very much. Good morning, everyone. I like to share. Everyone has bias. I like to share my bias in the next few minutes about the optimal treatment for uncomplicated acute type B dissection. And Dr. Prinya already showed nicely about the treatment for acute type B dissection, which I think we all agree and we all do the same thing, control blood pressure and things. And complicated type B dissection, we will need to fix it. And the TIVA seems to be the method of choice. What about the uncomplicated type B? Because in the guidelines nowadays, the current guidelines that we have in the past year or so, as I listed down there, optimal medical treatment is still recommended. TIVA is not the first choice that is recommended. They said that it may have some roles, to prevent aortic dilatation rupture, particularly in the high-risk patient. I will talk a little bit about high-risk later in my talk. But uncomplicated type B dissection, TIVA may be considered selectively. Is that an optimal treatment? Because I have questioned that to do OMT, optimal medical treatment only, is this an optimal treatment? We look at the natural history of this acute type B dissection. This is the data from Mass General Hospital in Boston in the US. You can see that in their almost 300 patients up to 6 years, intervention-free survival was only 40%, means that almost 60% of the patient will need something to be done within 6 years. Think about if the patient lived longer. What about that almost 60%? That 58% is 174 patients, 119 died. And those who survived, 87, there will be needed some intervention. Interestingly though, the green line, those who needed intervention means that they have to do TIVA or open repair, ends up having better survival than those who are doing only medical treatment. Is that interesting? They're more sick. They need intervention. If they survive, they can live longer than those who treated only medical treatment. I think that is quite interesting. So it is clear that acute uncomplicated type B dissection is not a benign disease process. Another data from California statewide, this is the population-based study, 10 years. In California, over 9,000 patients, they had uncomplicated type B dissection. Majority will be treated with medical treatment, 2% open repair, and almost 3% TIVA. Look at the survival up to 8 years. The worst survival is medical treatment only group. The TIVA group has the best chance to survive up to 8 years, and then open repair. And the worst is medical treatment only group. So it's also clear that acute uncomplicated type B dissection should be treated with TIVA. And again, this is the data to show us. This is the Emory in Atlanta, Georgia, aortic database. They look at their patients, almost 400 patients with acute type B aortic dissection, 80% complicated, means sick. Dr. Prinya mentioned that we do not think patient may die. They are sicker. And then majority is over 300, so were uncomplicated type B, supposed to be a more benign process. So if we think that uncomplicated acute type B should have better survival than complicated type B, we are wrong. Because the complicated group, they were treated, TIVA open repair, maybe mostly TIVA now. And those complicated type B dissection patients treated with TIVA end up having longer survival than those who were treated only medical treatment, best medical treatment. So I think it's clear that acute uncomplicated type B is not a benign disease process. It's also, we have evidence showing that acute uncomplicated type B should be treated with TIVA. And the complicated type B, even complicated type B that were treated do the acute TBAD, they end up having better survival than those uncomplicated type B that were treated later when it's complicated like chronic, open, or medical treatment alone. So if we're talking about the optimal treatment for acute type B dissection, is the medical treatment is the best one? I'm afraid may not be so. Are there any evidence for the RCTs? I'm not going to talk much about the INSET XL. We are all familiar with this. This is the old study showing that in a small study though, but a randomized control trial, endpoints all-cause mortality, and the secondary endpoints is the aortic specific mortality and the progression of aortic pathology. I just showed this, that with the TBAD group on the right-hand side column, the mortality, you can see the first 2 years about the same, but after 2 years, there were more mortality, much higher and significantly more death in the optimal medical treatment group. And this is quite important message that we all learn from the INSET XL. Do we have another RCT? Of course we do. The ADSORB trial, they use the core device. Unfortunately, this is a small and they follow the patient only 1 year. But they provide the same thing that the stent graft group will increase the true lumen, will reduce the false lumen diameter, it will induce false lumen thrombosis. But unfortunately, the number is not enough to differentiate, to show the survival at 1 year. But of course, we have a few RCTs to support that early TBAD in uncomplicated type B may be better than optimal medical treatment. But only 2 RCTs may not change the recommendation. So any other more evidences that can help us? Of course, there are many now, I would say, are familiar with I'm sure that everyone familiar with this IRAD study. Kritpracha also mentioned the IRAD. This is one of the very first IRAD presented to us almost 10 years ago. Show us again that the group that we treated with TBAD at 5 years, TBAD seems to provide a better survival compared to the optimal medical treatment. All these studies show us the same result, point to the same direction, that TBAD may be better than doing just only blood pressure and medical blood pressure control. The IRAD, Kritpracha mentioned this, they have like a review, the 20 years experience. They show us that the 5-year mortality, as I show you, TBAD provide lower mortality, and the fewer patients were treated. Now the trend in Europe, the trend is more people, the patient with uncomplicated type B, they were treated more and more with TBAD, not just medical treatment alone. And there are some high-risk imaging parameters, I will mention this a little bit later, that the partial false lumen thrombosis, large aortic diameter, false lumen expansion, these are bad parameters. If we see this, not good thing. And the treatment of the patients, I think this is something that worth discussion, but we don't have time to talk in this meeting, is that the treatment stent graft, with or without including that retrograde arch dissection, either IMH or dissection, the results are the same. So we may not need to go too far. But anyway, we have more and more evidence, little by little, increasing reports, even though we don't have the RCT, the big RCTs. But we have more and more evidence to support that the efficacy of TBAD is maybe better than just doing best medical treatment in uncomplicated type B. And I like this word, little by little in Italian, poco a poco. More evidence, and we're sure that we have poco a poco, little by little, the evidence keeps support that TBAD should be the first line of the treatment if we can do that safely. Like this study earlier this year, and if we do best medical treatment, the unplanned readmission is significantly higher. Almost 1/3 of the patient will have unplanned readmissions. It means that we have trouble unplanned operation means that we think we should be okay with the treatment with just medicine, but blood pressure control. End up we have to do something in that almost 28% in only 1 year. What if we follow these patients 3 years, 5 years? They're younger patients, right? 50, 60 years old. They're supposed to live a little bit longer, not even though not normal life expectancy, but they are able to live another 5 to 10 years. Then the risk of having problem in the future is significantly high. And the risk of intervention in this study earlier this year also support that the risk of intervention for uncomplicated type B in 1 year, 1/4 in 3 years, or 1/3 of the patients, or maybe more. So again, poco a poco, little by little, to support all the evidences that I showed earlier, that there are more evidence, but is that enough? Poco a poco, is that enough yet for little by little thing? I don't think unfortunately, I don't think it would change the guidelines. The question is, all the experts in the field, the specialists in the fields, I'm not sure that it's okay for the patients. If we wait for the guideline to change, we will lose a lot of patients of this. I'm not saying that every uncomplicated type B dissection should be treated, but I think we should think about the treatment for uncomplicated type B patients. In the guidelines, we talk a lot about the high-risk imaging findings. So I summarize here from a few studies from the guidelines that there are suggestions that if the patients have these imaging high-risk parameters, for example, total aortic diameter more than 4 centimeters, false lumen bigger than 2 centimeters, entry tear bigger than 1 centimeter, entry tear at the lesser curvature, the aortic diameter increased more than 5 millimeters between imaging studies, some bloody pleural effusion, of course, imaging only evidence of malperfusion, we would think this is the high risk. And then added from some studies that the false lumen partial thrombosis and the number of entry tears, if the patient had any of those, we consider high risk. This is the imaging high risk criteria. There are also the high risk clinical findings, as for example, the refractory hypertension, despite more than 3 kinds of antihypertensive medications, or pain, or need for readmission. This may be some high risk parameters. But from our observations and from many studies showing that even those uncomplicated type B without high risk factors, they too can develop problems. They are not totally benign. So, Mr. Chairman, ladies and gentlemen, I think that for acute uncomplicated type B dissection for now, we have 2 options. TIVA for all, maybe, except for a few. Or maybe TIVA for the high risk group that I mentioned in the last 2 slides, but certainly not just medical treatment for everyone. I believe that it is the question we ask is not who to treat. We have uncomplicated type B, we ask who not to treat, because majority of the patients, I believe that will be beneficial if the patient get the TIVA, but have to be lower complications in our hand, right? I'm sure doctors in our region, in Southeast Asia, we can provide the patient with very low complications. So I'm not sure that we can call it uncomplicated acute type B dissection. I think it's more appropriate to call it waiting to be complicated acute type B dissection. So we have to treat it as it's going to have some problems. Thank you very much for your attention.
Thank you, Dr. Boon. Okay, any question from the panelists for Dr. Boon or from the floor? Okay. I mean, one question, Dr. Boon. Yeah, you've mentioned if we can offer TVAR for uncomplicated type B, if we can provide do the procedure safely. Now, so far, I would just like to ask how far would you offer TVAR for this patient? Because, for example, patients with multiple re-entry dissected all the way down to the abdominal aorta, are you gonna go and cover the whole aorta, or how far are you gonna do the procedure?
Thank you, Dr. Kritpracha. For the technique, for the stent graft coverage, we know that the risk of paraplegia is quite significant in this situation. So if patients do not have re-entry tear inside the thoracic aorta, I think just one stent, maybe 150 to cover the main entry tear, that's enough. The re-entry tear in the abdomen or down to the iliac, I don't think we should go after all of those because the risk of paraplegia will be higher. We can leave that alone. Most of the patients, those false lumen will continue to disappear, maybe a few years. But if false lumen getting bigger distally, we can fix it later on. So I believe that for acute type B dissection, we just cover the main entry tear. If there is no re-entry in the thoracic aorta, we just do it like that. But if there is some re-entry tear in the thoracic, I think the recommendation is to also cover that re-entry tear because that is one of the high-risk parameters for problems that may happen later on.
Thank you, Dr. Boon. Any other questions?
I think I have one comment for if you put the stent in the uncomplicated, you have to know that in the some group of uncomplicated type B can heal by themselves. The God suggests that you can treat it with medical treatment, but until now we still don't know what the factor that this group of the patient can heal, this group of the patient cannot heal. So why we have the just like Ajahn Boonprasit said that we have the feature that they show in the CT scan, that why they suggest that should be put the stent in this group of the patient, not recommendation but suggestion. You have to know that because you put the stent in the patient, you have to know that it have complication and deadly complication. That's the problem. The stent is not simple. Stent is not the organ. It cannot merge to the body. You put the stent in the patient. You have to follow the patient. Until now, we still don't know that 10 years after that, what happened. Some group of the patient that you put the stent, they have the sign, rupture, and come back to the intervention. That's the problem when you put the stent in the patient. If you put the stent in, you have to know that you have to follow the patient. It's not, oh, you put the stent, can go home, you can go to work, anything. No, you have to control everything, not normal life. You have to know that.
Okay, thank you, doctor. Thank you.